Today is going to be a deep dive into back and neck pain. This is one of the most common chronic pain conditions. It's one of the most common causes of disability. It's a big problem in the United States and increasingly throughout the world. And there's a lot of misunderstandings around it that we're going to do our best to clear up today and hopefully give you really practical, useful information. If you're dealing with chronic pain, what can you do to recover, to unlearn the pain, to heal? So Jim Brusek is a licensed physical therapist in California. He has been practicing since 1998, treating all types of musculoskeletal issues. In the last 5 years, Jim has moved to treating primarily chronic somatic issues in the body. This was born out of his own frustrations in resolving chronic pain, and then the work of Dr. Sarno and the subsequent trainings with Dr. Schubner and other leaders in the mind-body field. And I just want to make a quick mention that Jim also has an amazing internet presence. He's really put a ton of time and effort into that. And so I recommend checking out his YouTube page and also his website, thepainpt.com, is an amazing resource as well. To frame the conversation, I want to mention a new study that just came out, which was a study that Howard Schubner, who appears in This Might Hurt, was part of. Research on people who would come into a physiatry clinic. They were not looking for a mind-body treatment. These were people who just had back pain. And they did an examination and an assessment. They took scans of the backs of these people to find out how many of them had structural damage problems, things that needed medical treatment in order to recover, versus a mind-body condition. So they had sometimes debilitating back pain, but nothing structurally wrong with their back that was explaining the pain. And what they found is that 88% of people who came in not looking for a mind-body treatment have mind-body back pain. It's an astonishing statistic, I think. 88%, right? And so, these are people who are often being told they need surgery. They're often being told their back will never be okay again. They're told all kinds of things by typical biomedical oriented clinicians. But the truth is that 88% have healthy backs, but really debilitating back pain or neck pain. And so that's what we're going to get into today. But I wanted to get into your personal history first, Jim, because I'm aware that you have your own history with pain. Can you talk a little bit about what drew you into doing this work?
Yeah, thanks. And thanks so much, Kent, for having me here today. And everybody, thank you for being here today. Really appreciate you coming here on a Sunday all day. So thanks for coming, everybody. So my personal history is, I would say, twofold. One is professional, one is personal. Obviously, I'm a physical therapist, and when I first started out my career, I was very athletic, wanted to get involved in understanding the body and how things worked, and I was always interested in recovery from injuries and fitness and competitive sports and things like that. And so I was fascinated by the body, but little did I know, fast forward 15, 20 years into that work, I would be working more on the mind and the body now. So I always had an interest in the body, and it came out of my own just being very athletic and very active. And then I also, and we'll get into more the professional side, but personally, I had bouts of different kinds of pain. I had low back pain. I still remember when I was in Australia studying my postgraduate master's degree in Perth, Australia, in Western Australia. I had back pain then that was nagging me in my lower back. And I remember at the time, I was, studying all this stuff about pain, and I was thinking, okay, I got to sit up with this posture. And I was in this, okay, lumbar lordosis, hold my posture, neutral spine, activate the core. Okay, sit here like real tall. And you know what? I had back pain then. And now I sit here with you today, and I'm sitting in my chair, fully relaxed. The belly is relaxed, and I don't have any back pain. And little did I know that I was going to go on a journey in Australia. Was the beginning of this journey for me, I would say, into mind-body world, working with people like Peter O'Sullivan, Lorimer Moseley, and people like that. Really opened my eyes to how pain works in the body. So I've gone through back pain. I've gone through sciatica pain, missed my foot for a period of time. And in retrospect, this is prior to me understanding this work, thinking it was a herniated disc. Looking back, reflecting that there was tremendous life stress at the time that could have been putting pressure on my system. Knee pain, chronic sinusitis, chronic anxiety, chronic hip pain. I've been through a multitude of things over the years. So personally, and then professionally, like you mentioned, yeah, my turning point again, if you want me to go into it more, Ken, I can from that
Yes,
physical
please.
world.
Yeah, how did
Yeah.
you?
Yeah, so it was born out of my own frustration. I started my career in New Jersey as a physical therapist, and I studied in Atlanta, Georgia, and Emory. I came back home and I worked for a while, and I was really wanting to learn and learn. I was taking classes and studying manual therapy and all these things, manipulation, everything I get my hands on. And I was working with this guy, and he was getting the best results with every patient. And I was like, man, what is this guy doing? And he was voted the top physical therapist in like the whole area where I lived. And I got to see what this guy's doing. And I would watch him. I go, what is he doing? He's not doing anything, but I can tell. But the patient, he's not doing any special manipulations or any special treatments. But what he was doing, I realized later, was that he was such a connector. He was such a person where he was really positively supporting the person and joking and making light and said, you're going to be fine. And, yeah, let's do the exercises. And he made everything very, very easy for people. And it made people feel safe, I think, in a lot of ways. And just that alone, I think, helped people. And I didn't understand that at the time. I thought, you do a mobilization on the shoulder, you get a result, or you do a treatment on the back, you realign the pelvis, you should get this result. And I found it wasn't happening for me, and I got more and more frustrated with my work. And I just like, what am I doing wrong? Is there something wrong with me? Then I start, am I not a good therapist, or am I not learning the right material? But I found there was like about 30% of people, it could be more. They say chronic pain is about 20-30% of the population, where nothing I could do would help the person better. And I think it was born out of that, how I opened the door. And then I went to Australia and I learned a lot more about pain science. Studied with this guy named Peter O'Sullivan, who at the time was studying core stability in the back. And I actually did research studies with him that was published in the Journal of Spine about multifidus and abdominal muscles, about core stability, activating your core when you lift something, when you move. And it turns out we published that paper, and he published like 80 papers. He's really well known in the research field. He's gone on to basically throw all that in the garbage can, in the rubbish bin, as they would say in Australia. And he's gone on to form a type of work called cognitive functional therapy. If any of you guys want to look it up, it's very much in alignment with the work that we do here. Getting away from that posture, core stability, these things that we take for granted, that we think there are issues in the back, are actually not the problem. And we talk some more about the fact that the core is contracted. It's tense, it's tight, it's constricted from emotions, from stress, from protection, from guarding. And so it's not really the weakness that we thought it was. It's more of the protective states that the brain creates in the body that cause this. And so he really taught me a lot. I came back and trained with him later. And I was like, Peter, man, you've changed your whole approach. He goes, I know, because the research wasn't supporting it. I give him a lot of credit, and he was a major influence to me. And then from that point, I came back to the States, started working again. That's when I found out about Dr. Sarno. He was still alive at the time. I'd reached out to him, and he had connected me to Dr. David Schechter, who's another mind-body physician in Los Angeles, who then got me with Dr. Schubiner, who I ended up going there to Detroit 3 times maybe. And he was such a great guy, as you know, Ken, because you spent a lot of time with him. It was early days before your film. And he took me in. I went and spent like a week with him seeing patients, and I learned so much from him and in subsequent trainings. And so that got me on the road of this work. And here I am today, helping people.
Amazing. Yeah, it's lovely to hear about researchers who are willing to question much of the work they've done once the data is not lining up as well as they wished, and reconsidering things and reassessing their priors. That's a great story. I know one of the things you shared with me that I found really so helpful in thinking about back pain is this thing he wrote about 10 myths and 10 facts about back pain. And there's so much misconception around back pain that doctors are telling patients every day, that the patients are taking in and then feeling like their back will never get better and that they're screwed, and what are they going to do? Could you talk about some of the myths and facts that he's written about?
Yeah, so him and his group has expanded beyond Australia now to Europe and the US, with people who are researching this and putting out content. Um, yeah, I'll read 10 back facts that they presented, and I'll just read them off quickly, and you guys can look at them at another time. But they're really quite striking. I'll go through the 10 of these things. Persistent back pain can be scary, but it's really dangerous. Getting older is not a cause of back pain. Persistent back pain is rarely associated with serious tissue damage. Scans rarely show the cause of back pain. Pain with exercise and movement doesn't mean you're doing harm. Back pain is not caused by poor posture. Back pain is not caused by a weak core. Backs do not wear out with everyday loading and bending. Pain flare-ups don't mean you are damaging yourself. And finally, injections, surgery, and strong drugs usually aren't a cure. So that's a lot there, right? And you can say that pushes probably a lot of buttons, or is conflicting with a lot of information that people learn about. But that's really what's come out of the research now. And here we are, 2023, is that we are not looking at the same thing that we're looking at in the 1950s or even the 60s, where they said, you have a back pain, you go get in bed rest for 10 days for a week. We've come a long way from that to now. And so this information is obviously not out there. One of the other clinicians, a colleague of mine, Dr. David Anscombe, he wrote a couple of books, Back in Control. He's a spinal surgeon, and he talked about recently. I heard him speaking about he got ran out of his practice as a spinal surgeon. They couldn't wait for him to retire. I heard him talking about this. He said his colleagues didn't want to hear the success stories. They didn't want to hear it. They said, "David, do your surgery." And so they were happy when he retired, similar to Dr. Sarno. So this hasn't been really well accepted on a national level, you could say international level, mainstream level, because it conflicts so much with what people's business is about. And it's not that people aren't well-meaning in their practice, but it will really shift the practice so much that people would give up a lot of spinal surgery.
Yeah.
Yeah.
Yeah, this just to add some context to what Jim was talking about. So, well, for one thing, spinal surgeries is how much income for hospitals? $50,000 or more, per a pop. And Dr. Hanscom, just for those of you who aren't as familiar with him, he's sort of taken on very similar or almost identical work as Jim in terms of realizing he was doing all these surgeries with people over many years, and then he realized like many of them do not need surgery to recover from pain because their back issues are not, anything he could find on a scan or he could do surgery on was not what's causing their pain. And he found that when he did he called it prehab, where he would work with people on getting better sleep, calming the nervous system, reducing fear. And then sometimes their back pain would go away. And then once he realized that, he really doubled down and found that he was diverting so many people from surgery that the hospital didn't want him anymore. And that's what Jim was referring to. So yeah, there's a reason why you may not know about these facts that Jim mentioned. There's a huge, huge financial incentive for medical centers to hide these things and for doctors not to know about them. This is the situation with back pain. It's different than some other chronic pain conditions because it's extremely lucrative to give people treatments for back pain. And there's so much confusion around whether or not people have something structurally damaged about them. Rachel asked a question, is there anything specifically for people who have SI joint pain?
Yeah, so SI joint pain, that's in the bottom of your spine, the coccyx, right? The connection between you can say your sit bone and your back, a triangular bone, upside down triangle bone, and connects to your pelvic bones. When people always talk about your pelvis and your SI joints slipping or they're out of alignment, and there might be something to that, but the research doesn't really show that. When they looked at the discrepancies, the millimeters difference, that there wasn't difference between people with pain, not without pain. I think it's just another condition, unless there's something that is very structurally causing damage, like a ligament damage. There have to be quite acute. There is some sacral joint pain with pregnancy, because the ligaments do loosen up, and so there can be some more movement there and sensitivity there. That's true, but by and large, it's nothing really damaged there. There's no disc there. There's literally just ligaments connecting the sacrum to the pelvic area. You do have movement in your pelvis, and it can move up and down, in and out. But what happens a lot of times, it's the muscles that are pulling on these bones, the connection points. And I always tell people, what causes the muscles to contract? Unless there's a local injury there, let's like imagine a hamstring strain. You tore a hamstring or you strain your hamstring. That's a local injury. So outside of some injury to your muscle or to your ligament, it has to be driven by your nervous system. Okay, it has to be driven by an input from your nerves. Which where does that come from? Well, it comes off your spinal cord, which comes off your brain. So when somebody would come to me and this is for years, I would like, okay, let me correct your pelvis. I'm going to align your hips. Good, you look great. Oh, it feels a little better. Oh, great. I'll see you in a couple of days. They would come back and I would do that like 10 more times. And it'd be like, it's not changing anything, right? For the moment, it switched something. It's like getting a massage and it feels better for the moment. And that's because the central nervous system is just, it's kind of like it's tightening the system back up or tensing the system up again, either from protection or from other mind-body processes we can talk about. But I think a lot of people don't understand that. They think that everything's got to be localized. But again, unless it's an injury, it has to fit the timeline of something that would heal. You mentioned that, over 80% of the people don't have any organic cause of back pain. At the same time, the large percentage of people, over 80%, heal from back issue. And 80% of the population in the world have back pain at some point. It's really a large population, but the vast majority of them get better. So what about those 20, 30% of people that aren't healing in the normal amount of time? There's got to be other things going on that's not normal, that's not typical in the body. And that's what we get to these mind-body type issues.
Let's talk about just broad categories of if you have back pain and doctors have said you need surgery. Like, what are the categories where you're like, oh yeah, that is a good chance you may need surgery versus you should be assessed for a mind-body condition and consider mind-body factors?
I mean, it's a pretty small subset of conditions that need to be shuttled off to, let's say, surgery in an acute way. It needs to be things like acute infection, tumors, cancers, which aren't quite common, fractures of the spine, and acute, let's say, severe disc herniation, disc protrusions, prolapses, extrusions, where there's literally an obstruction in the spinal canal that's pressing on the nerve root. And not just that, but it has to be causing very real identifiable symptoms such as motor loss, which would be loss of, like, let's say a foot drop would be a common thing, which is weakness. It would have to be associated with severe loss of sensory change, as well as possible bowel or bladder changes. Okay, those are some of the bigger signs we're looking for. And you definitely want to rule those out. Those are red flags, call them. We want to rule those out because there are a subset of people who have those, but like you mentioned earlier, Ken, it's quite small. It's very small. The vast majority of people don't have these conditions. They have idiopathic back pain, which is nondescript. Don't know, or at least the doctors don't know. There's no identifiable organic cause for it, according to the doctor.
Doctors will generally not say, oh, you have mind-body back pain, right? But there's certain things they might say that are hints. And if I remember right, in Dr. Hanscom's book, he talks about axial back pain, which I think is related to oftentimes nonspecific back pain. Whenever a doctor says nonspecific pain, that's their way of saying we can't find a obvious structural cause of this pain, but they'll never say it's mind-body. That's the part the patient unfortunately has to take it upon themselves to look into. What does nonspecific back pain mean? Why would I in particular develop nonspecific pain? And so you mentioned the main things in terms of structural damage that may need medical treatment. Then, there's all these things you hear about: a small herniated disc, a bulging disc, things like that. Can you talk about words that sound scary about the back that are often just a mind-body condition?
Yeah. Herniated disc is a real, buzzword or triggering word, you could say, a nocebo word in a way. It can cause pain. It has to line up, really specifically with the neural pathway of where that herniated disc is, and it has to be of a certain size. But even saying that without the things I mentioned before, like severe motor loss or bowel and bladder changes, these things heal. And there's been many studies showing that whether you get a surgery or you don't, the outcomes are similar. It might take a little longer. If there's an acute herniation, it might take 6 months, a year, but by and large, people return to normal. Okay, but with the gray area you get into is when it's not considered a diffuse or large herniation, and you're into that zone of like, oh, you got small herniation, small, moderate, and then even down from that, you got a disc bulge, you got you got something like that where it's even lesser of a concern. So as you get down from some of these other severe things like a severe disc herniation, there's less and less data showing that there's a correlation with pain. And there's been a lot of studies on that with asymptomatic people.
Right. The classic study is it's basically everybody as they age has disc problems. It's just called a normally aging disc. If there's a little herniation, a little bulging, a little thing like that, we all have it. And many of us have no pain. So the fact that you have issues with your discs is not really good evidence, generally speaking, that it's causing your back pain.
Yeah, that was a 2015 study at 3,000 people across multiple studies. And as you get older, it's more and more and more. But if you think about the prevalence of back pain doesn't go up at the same rate that the changes are going up in the back. And I'll add one other thing that kind of shows the idea of the mind-body connection. They did recently, I think it was last year, a double-blind study on surgeons with two groups. Half group, it was about MRI reports, what they found in the person's back. And half of the group, they just reported, the surgeon just reported the factual findings to the patient. And the other half of the group, they reported the findings. And the word in the study was reassurance. That was the word they used. They reassured the patient that these are normal age-related changes. Continue on with your life, exercise, carry on. But over 6 weeks, only in 6 weeks, there were completely statistically significant differences in outcomes, pain-related outcomes, disability outcomes. I mean, it was incredible to see that information. Now we're getting into the mind. Information can absolutely skew a person's outcome.
To linger here just another minute, I feel like one thing that I found informative is that oftentimes if you have damage in your back that is triggering your pain, it'll often be, correct me if I'm wrong, you'll find symptoms in the legs actually, or it's not necessarily going to create pain in the lower back. Can you talk about how we need to map in a little more detail, what kind of mappings to something at L5S1, how do we make sense of those findings?
Yeah, so that's the idea of one of the ways to diagnose structurally related pain or mechanical pain is the nerve roots, the pathways of the nerves. So for example, L5S1, go down a particular part of your leg, let's say down the back of your leg and down the back outside of your leg, down to the portion of your foot. Okay, so there's what we call a dermatome and a myotome. And those are the actual pathways where the nerve can go. So if it's going outside of those pathways, or the pain is diffuse, moving around, or it's shifting outside of what would be considered a pathway, then that's evidence that it's not due to that disc, or it's not due to that nerve root, because it doesn't make sense. And a lot of people, the pain is spreading, it is moving, shifting even to the other side, which doesn't make any sense, right? So you have to look at the evidence. And I think that's what I really try to help people with. It's evidence-based. This is not a faith healing. This is evidence healing. And we want to start with the foundation of what's happening for you in your body. Give me your history, what you did, what happened to you, all your scans, and then tell me about you. Maybe we'll get into that. Tell me about you as a person. Who are you? Did you grow up? What are your personalities like? How do you deal with your emotions? You got stress going on. So we want to know much broader picture. I want to know much broader picture than what I learned in physiotherapy school, which is, okay, look at everything's physical. How are they bending? How are they moving? Here's the pain. And you never even think to ask about their life. So to get back to your question, it's very specific, and we can determine based on that. Now, a lot of times you can have pain shooting off because of trigger points in muscles, tender points, they're called, and they can refer pain as well. And they'll refer pain in different pathways than, let's say, a nerve root. But a lot of times those things are TMS, right? Dr. Sarno, one of his things, many of you may not know this, but when Dr. Sarno did his assessments, Dr. Schechter still does this, he would push on tender points in the body around, you'd push on, I think, I can't remember how many, but you push on different parts of your body. And if you scored with a lot of tender points, then he would say that was more evidence for TMS. Okay, because the nerve input causes these tender points in the body.
Hmm. Yeah, so, and I just want to add something, Jim, to what we're talking about. So there's all these specific to back pain ways to assess, is this a structural problem or is this more likely to be a mind-body problem? And then apart from back pain, there's the same types of criteria we use for all different mind-body conditions, which is, does it switch on and off? Do you have it on the weekdays but not on the weekends? Not on vacations? Is it way worse in the morning? Is it way better after you get a massage, which wouldn't have like a structural impact on the body part, for example? Is it worse with stress? Do you have multiple different kinds of pain? So not just back pain, but also pains in other parts of your body. These are all ways of trying to work out how likely it is you have mind-body issues. And so they call that the criteria for if it's like kind of, if it gets triggered by things that shouldn't really trigger pain, if it's structural damage, if it's inconsistent, does it spread? Is it kind of growing over time? Is it getting a lot worse over time? These are other ways you can start to like ask yourself questions and do some of your own assessment. It's best if you can work with a coach like Jim or somebody who can help you with this, but it's also possible to learn these baseline ways of assessing yourself so that you don't have to spend a ton of money visiting with doctors and getting tests when it can be pretty, sometimes the picture is pretty clear once you just ask a few questions about the symptoms. So I wanted to mention that. So Jim, let's get more into the treatment. So if you have figured out that you think you either have a mind-body problem or a mixture of structural and mind-body, that can also happen. Can you describe the treatment that you do?
Yeah, so once the diagnosis of like mind-body syndrome is made or PPD, then we move forward. I always tell people, look, we're going to take the focus off the body, at least on a structural way, and we're going to move it to your brain and nervous system. And when we move to the brain and nervous system, now we're looking at different things. Now, for example, posture doesn't become as important. Strength doesn't become as important. Flexibility doesn't become as important, right? Those are all physical attributes to the body. Not that those things aren't helpful for people, because they could be, but they're not the things we're going to focus on for healing anymore. I encourage people to do them, absolutely. But our focus points now are in the mind. So when you think of that, I like to lay it out pretty simply. You can think of it like you think of CBT, but I call it CBE, cognitive behavioral emotional categories. And they kind of cover all the aspects that your brain and mind encompass. So cognitive is, your beliefs, what you've been told. We know a lot of nocebo. It's called nocebo. Like I mentioned that study to you before, those are nocebo beliefs. Self-limiting beliefs, negative beliefs can cause and contribute to symptoms, thoughts, how we're thinking about things. So that cognitive aspect is important. And then your emotional aspect, as we know, Dr. Sarna really highlighted this, is very important, because people who have a tendency to repress emotions based on who they are, their upbringing, and so forth, have a greater tendency to have pain in the body. And that's been proven over and over again in multiple studies. So how we process our emotions can have a large impact on symptoms. So we need to address the emotions. Very important. And sometimes we need to address the past too, because that's where some of these issues started. Trauma, for example, PTSD, things like that are contributing factors or potentially contributing factors to now, like ACE scores, things like that have been proven in multiple studies to be related to symptoms later in life, health outcomes. And then behaviors. So behaviors are, what you do, how you move, what are you doing, how are you behaving during the day, basically. And we want to teach people to essentially get away from avoiding things that they are avoiding because they're afraid. There's another emotion, right? We're afraid of pain or afraid of the symptom. Because as you know, Ken, you can put your 2 cents on this as well. The whole purpose here is to teach the brain, the limbic brain, there isn't any danger. There isn't the threat that the brain's perceiving, which is producing in the body. So the symptom itself is not threatening anymore. It's not representing the danger like we would think it would represent. And so we can start with that, and then we can explore these other aspects, like I mentioned,
What you're describing, they've sort of branded these treatments. So one of them that you saw in our film is called emotional awareness and expression therapy. And Dr. Howard Schubiner in the film worked on innovating that treatment. Then the other treatment that is similar but has some differences is called pain reprocessing therapy, which focuses more on what they call somatic tracking, which is a type of mindfulness where people track the pain in their body with curiosity and remind their body and their mind that they're safe, that the sensation of pain is not necessarily a threat. And Jim, can you talk a bit about the evidence base for pain reprocessing therapy?
Yeah, PRT, brain reprocessing therapy. That was just such a groundbreaking study, out of UC Boulder, Yoni Ashar and Tor Wagner and Dr. Schubiner, right? Alan Gordon. Really, that put it on the map just with back pain. So they took people in that study just with back pains. They very singled out that sort of diagnoses. And again, they excluded people who had any serious conditions they thought might be structural. And what they found was taking people through this PRT process is they had a dramatic reduction in pain. The results were astounding. I mean, 66% of the people became pain-free or nearly pain-free doing that. And that process with that Alan Gordon's teaching, it's funny because I remember doing that training with him and Howard before they launched it all, formally. And I think you guys might have been even filming one of the sessions there in Detroit when Alan was there. But yeah, it was amazing to see how people could shift their perception basically of their pain or their symptom into that neutral way of seeing it as a sensation and how that could completely shift the pain. And that really proved again that a lot of this pain was driven by the mind. It was driven by the brain. I mean, to get those type of results.
Yeah, we were filming when Alan was presenting to a group and he worked with somebody on the stage, and she has this sort of dramatic experience of recognizing something going on with her neck. And I'll post a link to that in the description and in the chat in a minute. But Jim, I was wondering if you can, I had talked to you ahead of time that you might be willing to guide this whole group here. So rather than watching a video about it, you can actually experience it yourself. You can go through and Jim will guide us in that. Are you up for doing that?
Okay, let's do that, because I think that's the best way to experience this approach than just talking about it. So everybody here, why don't we all just get comfortable in your seats? I'm going to ask you if you're comfortable, you can close your eyes, or if you're not comfortable, keep your eyes open, but just relax your gaze. We're going to go inward for a bit here and just bring our attention to ourselves, to our bodies, okay, in a very gentle way. And before we do that, I just invite you to relax yourself. Just invite you to let go, in a sense, of your body. If you notice tension in your body anywhere from your face to your shoulders, to your stomach, to your back, to your hips, to your legs, to your feet, just see if you can let go of some tension in your body. Just relax, basically. Soften or relax into the surface you're sitting on physically. And I also invite you to relax your mind as we go through this, that this process is not so much about doing or fixing or solving anything. It's more about just opening to your experience right now. So I'm going to invite you to let go on a mental level as well. And just let yourself really fall into this space right now, into this present moment that we are in together, all of us. And we're going to bring our attention to our bodies right now, internally bring our mind's attention to our bodies. And I want you to notice if you have any sensation in your body right now. And the sensation could be neutral, it could be pleasant, it could be uncomfortable, it could be strong, it could be weak, it could be any number of variations of intensity, variation, quality. Whatever you feel in this moment here together with all of us, I'm going to invite you just to open to that sensation and simply allow that sensation to unfold in its own way. Your job here right now is to relax into what you feel and to see this sensation or these sensations in your body as just a sensation. It's not something we need to do anything about. we need to tighten up on our bodies, or we need to fix it or shift or try to make it go away. The only thing we're doing right now is opening, allowing, and relaxing into whatever we feel. So the sensation gets stronger, or it moves locations, or it changes how it feels, or what it is like. We continue with the same opening, acceptance, and allowance of that sensation. Now, whatever you feel right now, you're sitting here in this very safe space. You're just sitting in a chair. You're very safe and comfortable. That whatever's happening now is just a production of your mind. And because it's a production of your mind, we can simply allow whatever you feel to continue to unfold. And just notice if your mind wants to go off somewhere else, it's completely fine, or it wants to try to do something about the sensation to stop it or move it somewhere else or make it less, something like that, or anything you notice that could be a reaction to what you're feeling or a resistance to what you're feeling. I invite you just to drop both those things and just open more deeply and surrender more deeply to whatever you're experiencing now. And as you are experiencing this right now, the sensation, the symptom, the feeling, just continue to attend to it with a very light, gentle curiosity and openness, not an intentness or a seriousness that there's something wrong. Just more of an openness that you want to say, okay, this is good. Let this calm and let the sensation do what it needs to do. It's perfectly fine. And see what happens to the sensation or the symptom or the feeling in your body as you continue to open to what you feel. As you continue to just feel what you feel without blocking it, resisting it, fighting it, judging it, wanting to make it go away. See what happens to that sensation or feeling. How does it feel? How does it feel? As you notice it, what's the quality of the sensation? Without calling it a word like a pain or a symptom, how does it feel in terms of a quality? Does it feel heavy or light or sharp or dull? Does it have a weight to it? Does it have a pulsing to it? How would you describe it? Just in words, just noticing that. But again, from a very neutral, open, understanding place in yourself. And just continue to observe these sensations or feelings in your body. Again, if your mind wanders off, just normal, just bring it back to yourself. Bring it back to what you feel. In a way, what we're doing right now is we are facing our feelings. We're facing our sensations in a very particular way, which is called pain reprocessing. You're just attuning to what you feel right now in a very neutral, observing way, which is teaching the brain that what you're feeling is safe, what you're feeling is not dangerous or threatening, and that you can feel what you're feeling now without having to do anything to it, other than to reinterpret it as being okay, which is allowing it to express itself in any way it wants. Because it's not dangerous, it's okay. It's just a production of your nervous system, brain in your body. So a few more minutes of just attending to yourself. What do you notice happening since we started the process? What are you feeling? There's no right or wrong answer. The purpose here is not to make your symptom go away. As much as I know that seems to be the intention here. The intention here is to teach the brain that what we're feeling is not threatening or dangerous in the way that we perceive it, in the way that we feel it, and the way that we handle it right now. And in doing that over time, the sensation or symptom will shift. We have no control over when it happens. It doesn't even matter when it happens because it's not dangerous. So the more we try to make it go away, the more we might be signaling to the brain there's something wrong. It's very paradoxical in a way. Just relax. Exhale. Just relax into whatever you experience, completely and utterly allowing the experience to be here right now, to unfold in whatever way it wants, because it's fine. No resistance to what you feel right now, and no reaction to what you notice in yourself. Just simply reinterpreting and reprocessing what you feel in yourself as just being a sensation that's produced by your brain and nervous system. And notice what happens to it as you become that observer of yourself. Not the person who's trying to, again, fix, change, stop, alter in any way what you feel. So in a way, this is the practice of curiosity, gentleness, relaxation, surrender, parasympathetic nervous system activation, teaching the brain that we're safe and we're okay, teaching the brain that we're not scared of what we're feeling. So it serves a lot of purposes here, this practice, to be able to tune to yourself in this way, is really teaching the limbic brain again that we're safe, that there's no danger, there's no threat in what we're feeling in our bodies. So just gradually make your way back to the space now. You can just open your eyes slowly, come back to your surroundings, and just see how that was for you to experience your body that way, what that experience was like for you. How you feel now, if there were any differences from when you started. And the purpose here, again, as hard as it is not to change the symptom, but it's to change your perception of the symptom. And in doing that is what changes the symptom ultimately. That's the purpose of pain and reprocessing therapy. Do you have anything to add about that?
No, that was so great. Very relaxing. Yeah, it's such a powerful practice. And, I guess I do have something to add, which is that when I've done this practice with people when working with clients, you often discover astonishing things. It's not every time, so this doesn't happen every time, but sometimes people's pain will disappear in the middle, or it'll go down by half just by attending to the pain differently with a different mindset. And when that happens, you spend all this money on MRIs, but it's like that is also a way to diagnose pain. That's a clinical finding, that adjusting how you attend to the sensations, if the pain dramatically drops, that's really useful information and can help you reach an assessment of mind-body cause. Because if you had an infection or cancer, paying attention to it does not have such a dramatic difference in reducing the pain like that.
Yeah, and also to add, if it goes up or even moves location, there are also other clues for being mind body.
Yeah, and so this is something you can do with another person. Some people really struggle with somatic tracking. It's deceptively simple in a way, and sometimes they do it where they're really like, ooh, they have some subtle underlying pressure where they really want their symptom to go away, or they're like, I'm being really curious, but they're actually full of tension and they can't quite do this mind shift. And so a coach can help them see that. They can see the ways that they're resisting or not able to engage in the process in a way that can bring relief. And so if you're struggling with somatic tracking, I suggest working with another person. It can be a therapist, to kind of learn that skill, because it's a skill that can serve you for your whole lifetime. I wanted to ask a couple questions. We're going to depart from the topic of back pain for just a minute, because Jim treats all different kinds of mind-body symptoms, and there's a huge array. There's over 30 different ones that we've documented on our website. Pain can basically happen anywhere in the body and be a mind-body condition. So somebody, let me see here, Andrea asked, she said, can you speak to pain related to diverticulitis, IBS, and hip pelvic pain.
Yeah, like you alluded to, Ken, once we roll out any structural cause, a lot of these conditions don't really have an identified organic cause. The doctors can be vague. They don't know what it is. We can't see there's one of those structural mechanisms taking place. Then it falls into the category or under the umbrella of mind body. So you can have IBS, especially diverticulitis. There's a whole number of symptoms or diagnoses, you could say. There are more, I would say, that are mind body. And the way you want to know that is just through the person's history. So once we get their history, we have an idea what's causing this. And some of these are straight up just nervous system produced. Like IBS is definitely one that's usually due to nervous system disruption or dysregulation. They call this functional disorders. And they use that word because it's not specific. They can't come, that's like fibromyalgia, it's a functional disorder, chronic fatigue, some of these things. So they don't find anything specifically wrong. If you didn't break your bone, there's not a ligament gone, there's not a severed artery, right? So it's more systemic, you could say. And that, when you start looking at that, now you're looking at the nervous system and brain.
Functional is one of these puzzling medical terms where it doesn't mean what you would think it means. So functional generally means there's not an injury that explains. There's not a clearly identifiable medical injury. And but they don't tell you that you should look into mind-body things usually. But if a doctor says this neural issue you're having is functional, or this bowel issue you're having is functional, that's just another way of saying biomedical interventions will not be able to help you. And so it's a very, very likely that it's mind-body related, and that people who do mind-body practices like Jim will be able to offer help. But that's another confusing one. It's like functional. You have something functional. What does that mean? And then we didn't talk about. I think arthritis in the back is an interesting topic. Lupe asked, "Can you speak to joint arthritis, hips, knees, and joint replacements?" And I also want to add in there, like, I know somebody who is much older, has lots of arthritis in their back, and thinks that is the cause of their pain. And so, can you speak to arthritis, and can you differentiate osteoarthritis from rheumatoid arthritis?
Yeah. And well, both of them are inflammation, itis, anything with the word itis on the end of it is some kind of inflammation in the system. One is more around bone, right? Rheumatoid more systemic in a way, immune system type of stuff. But the osteoarthritis and rheumatoid arthritis both have pretty strong links to mind body. In fact, if you want to Google the Osteoarthritis Foundation or the Arthritis Foundation in the US, they have a whole page to the brain, which is quite awesome. And they talk about how the brain can basically, they said, without a brain, you don't have any pain, and how it can be an amplifier for any arthritic type pain conditions. Well, saying that, yes, there's studies, from what I understand, from what I've read, is that if you have severe change in your joint, let's say a very severe arthritic change, there is evidence that is related to pain. There is more prevalent pain. But if you have mild to moderate changes, the evidence isn't very clear or as conclusive, meaning there's tons of people going around with arthritic changes. They don't know it because they don't have any pain. So it's like that. You really want to look at the entire piece of the puzzle, the severity of the change, their history again, in relation to what the research says for those particular findings. But yeah, I would say by and large, arthritis is influenced, if not contributed to, or even caused by the brain. So we have a lot of evidence coming out now to show that the brain changes with those type of conditions. We develop what's called central sensitization, which is a central mechanism for producing inflammation now, not from, let's say, the knee or the hip anymore, but from the brain and spinal cord and receptors in the nerves, that they become sensitized. And it's that sensitization that is causing more of the pain than it is the actual local tissue or joint.
That's so helpful. Thank you. So we're going to close out now. Firstly, I just want to thank Jim so much for partnering with us to co-present this film.
If you're struggling with chronic back pain, neck pain, then it's worth exploring these principles or this area if you haven't already, because I think acute pain is a different thing. It typically goes away. Like I said, the vast majority goes away. And I'll leave you with a study that was done by Vanya Apkarian. He's a pretty well-known researcher. It was at Northwestern, I think, at the time. It might still be there. He followed people transitioning from a subacute back pain into chronic pain over 3 years. And he was doing brain scans all throughout that period, at the time of the initial back pain, all the way to the end of 3 years. And what their data found was that they could predict with upwards of 90% accuracy, looking back at the data, who was going to get the chronic pain. It's quite incredible. And it had to do with the emotional brain. It had to do with the brain, the cortical limbic brain. So meaning you can think, what? Stress, right? Some kind of stress to the brain that was a contributing factor to causing the pain to become chronic. And they went on and look, this is going to change the way we look at pain, because it was the brain that was causing the chronic pain, not the back. Now again, that didn't transform medicine, did it? But I think that was done in 2012. So it's been a while, 2014. But that really showed you that, this chronicity of 20, 30% of people is not due to the structure typically. It just usually isn't. And when you get somebody's history, you can see there's a lot of other psychosocial factors that can contribute to this. So I'll leave you with that.
Awesome. Thanks so much for everything, Jim. Really enjoyed talking with you today, and thank you all for joining.
Thanks everybody for being here. Thank you so much. Bye.